Hey folks, Scott Weingart here, and this is a very special EMCrit Wee. We are breaking news. These results of the trial we're about to discuss have just been released from embargo. This is the first place you're going to hear about it. It's being presented as we speak in the Critical Care Reviews Down Under conference, and I was lucky enough to get joined by the lead author, Jonathan Casey, and Brian Driver, emergency airway researcher extraordinaire, for the ketamine versus etomidate for tracheal intubation of critically ill adults, the RSI Trial. So this trial was conducted at 14 sites, 6 EDs, and 8 intensive care units across the United States. It enrolled adult patients undergoing tracheal intubation. The patients were excluded if they were pregnant, they were prisoners, they had trauma. We'll talk more about why that happened. Or they had an immediate need for tracheal intubation that precluded randomization. This was one of those clinical equipoise trials. So if a patient was clearly felt by the clinicians involved to need either etomidate or ketamine, then they did not include the patient in the trial, and they just gave them the drug they thought they needed. Patients were randomized, and the study was unblinded. So for the ketamine group, clinicians received a nomogram that listed full dose, 2 milligrams per kilogram, intermediate dose, 1.5 milligrams per kilogram, or a reduced dose, 1 milligram per kilogram. And they were able to choose based on their own gestalt of what the patient needed between those 3 dose ranges. So the clinicians chose, but those were the 3 they could choose between. So between 1 and 2 milligrams per kilogram of ketamine. In the etomidate group, it was 0.3 milligrams per kilogram, an intermediate dose of 0.25 milligrams per kilogram, or a reduced dose of 0.2 milligrams per kilogram. And they would choose one of those 3 doses of etomidate. Everything else in the trial was pragmatic. The clinicians could do as their clinical care dictated, including choice of muscle relaxants and all of the peri-intubation stabilization procedures. All right, let's talk results. They enrolled 2,365 patients. The primary outcome of the trial was mortality by 28 days. And there was no difference between the 2 groups. There was a 1% difference in the point estimate, with ketamine being favored. That was not statistically significant. And in the adjusted risk difference, it was minus 0.8 percentage points for ketamine. Again, not statistically significant. And they did multiple analyses to look at that mortality, and there was no difference in any of the subgroups, including machine learning, as you'll find shortly. Now, pre-specified secondary outcome was a composite of cardiovascular collapse during intubation. And that was an occurrence of any of the following between the induction and the next 2 minutes after tracheal intubation. And that was systolic blood pressure less than 65, receipt of new or increased vasopressors, or cardiac arrest. So for that secondary outcome, 22%, 22.1 to be precise, in the ketamine group, and 17% in the etomidate group had that composite endpoint. That was statistically significant. In patients who were septic, the cardiovascular collapse endpoint was in 30.6 in the ketamine group and 20.9% in the etomidate group. So almost 10 percentage points absolute risk reduction, and that was also statistically significant. And then in patients with high Apache scores, it was very similar, 31.4% in ketamine, 20.7% in the etomidate. So a clear signal in that secondary outcome in all categories. Ketamine was worse in terms of cardiovascular collapse. Now, they did further analyses in terms of various blood pressure cutoffs, and in all of them, ketamine had a lower blood pressure than etomidate. Then, after 500 patients in the trial, they started looking specifically for the occurrence of ventricular tachycardia, and that was also more common in the ketamine group, 1% versus 0.2%. And they actually, in the supplement, went through each of the patients with ventricular tachycardia. Now, cardiac arrest overall, there was no difference between the 2 groups, but there was an increased rate of ventricular tachycardia. The trial is clean. There's not too much to actually look for as nitpicking points or things that would make you clearly say, oh, I'm not sure these results are really applicable to my clinical practice. One thing that was brought up by my friend Chris Nixon, we're actually writing a letter to the editor on this, is that the doses of ketamine that were chosen, it makes complete sense why they were chosen. These are actually the FDA recommended doses. That being said, for many of us, including Chris and I, these doses are much higher than we would use in clinical practice. But They are the clinical doses that I imagine most people are using in clinical practice, but not the doses we would use. And for both of us in a patient who has risk of hemodynamic decompensation, we'd probably be starting at a 0.5 milligram per kilogram dose of ketamine and only adding more if in DSI fashion the patient required additional meds to be dissociated. Now, both of us also dose based on ideal body weight, and this study was using actual body weight. So these patients were receiving higher doses than both of us are actually using in our clinical practice. That being said, I think these doses are very close to what most people are using in clinical practice. And so with that being really the only proviso I could give, let's roll right into speaking with the authors about their visions of what occurred and what we should be doing now. So without further ado, Jonathan Casey and Brian Driver. Why don't we start with you, Jonathan? We'll give you lead author primacy here. Who are you and what do you do?
Well, thanks for having me, Scott. So John Casey, I am a adult pulmonary critical care doctor at Vanderbilt, and I direct the Coordinating Center for the Pragmatic Critical Care Research Group.
Love it. And Brian, you've been here before, but just remind people who you are.
Yeah, sure. Thanks for having us today, Scott. I'm Brian Driver. I'm an emergency physician at Hennepin County Medical Center in Minneapolis, and I'm the director of clinical research there.
Love it. All right. Now, the reason we're talking is the RSI trial results. We have these early. We are embargoed. This will be published at the time we're allowed to release it. And oh my gosh, this was quite a read for me. I will first say this was an exemplary study. This was beautifully done. I always am looking, what could I pick apart here? Can't really find much to touch on this trial. Wow. So I will have already reviewed the entire PICO and results of the trial for the people before they're hearing this part of it. So we don't have to go over that. So the first question I'll pose to either or both of you is, what did you expect going in? What level of equipoise did you have? Did you already have a hypothesis in your mind of how it was going to turn out? And was it surprising to you?
Well, I'll let Brian start. Brian did a single center version of this before we started, and we based some of our protocol and EFIC plan off his trial. So I'll let him give his thoughts based on his work in this area, then I'll tell you what we thought.
Yeah, so way back when I was a resident, I did a very small version that had many flaws, unlike the current RSI trial. But going into this study, honestly, I thought it would be negative. It was my hunch, but I wasn't sure. And my biggest worry was whether we'd enroll sick enough patients that if there was going to be a difference, would we find one? That was my biggest worry. But I thought my hunch was it was going to be a negative trial.
All right, Jonathan.
I can claim what I would have thought, but it's available as part of the manuscript. The protocol from the 2021 version is available, and people can see that I thought at the time that ketamine might improve mortality and improve cardiovascular collapse, improve blood pressure outcomes. And I'll tell you, I come from an ICU setting where we use nearly all etomidate, and 8 floors down, our ED colleagues use nearly all ketamine, and you all seem to care about this so much more that I thought you guys must be right. So when we planned the study, I really believed and hoped that ketamine might be better in both regards. I continued to hope throughout the study that it would improve mortality, and we could talk about some of the other trials that suggested that. Even during the conduct of this trial, additional evidence came out that made us even more hopeful. But the blood pressure evidence during the conduct of the trial went the other way. So while we were conducting the trial, observational studies from the NEARS registry and a single center trial, the EVK trial in Texas at UT Southwestern, suggested that ketamine might cause more hypotension. So I didn't know, but by the end of the trial, I wondered if they might go in different directions, if we might improve mortality with ketamine but hurt blood pressure. So that was what I thought and hoped we might see when the trial was finishing.
No, it's fantastic to hear from both of you. I'll tell you, really sat down and said, okay, Scott, what is your pre-reading? Because I had it in my email. I didn't open it yet. What do you think it's going to turn out to be? And I was pretty sure there would be no mortality difference, just like Brian. I did not expect the hypotension signal. That was a surprise to me. And so that's amazing that this trial is able to show that. And this is obviously the largest and best wrought trial on this issue to date. So we have some real compelling evidence. So that's what I want to talk about. The mortality, again, didn't go against my expectations. Did not expect to see this hypotension. So it was a composite of cardiovascular collapse, but it was almost entirely fueled by the need for additional vasopressor or a new vasopressor that wasn't already there because there was a drop in the blood pressure. So what do we make of this to start with?
Is it okay if I ask you, as an expert in this space, before we go to the secondary outcome, about your thoughts on the primary outcome. So your prior beliefs was there wouldn't be a difference. I think one question that I have for the community is, do people feel like this issue is settled? So that the primary outcome has a 0.8% effect estimate on the side of ketamine, but the p-value is 0.65. The all location mortality shows no difference. The subgroup around sepsis shows no difference. So I'm wondering how the community will interpret this. My belief is the same as yours, that it really answers the question around mortality. Do you think there will be people who are less convinced who want a bigger trial?
I can't imagine, because the way I've always laid it out in my head is we know there's an adrenal suppression. We know in current critical care management that if a patient had escalating vasopressor doses that might be as a result of that adrenal suppression, we're going to supplement them with steroids. I can't see how it's going to affect mortality. We don't have a definitive answer from this trial or any of the trials of, is there anything meaningful from that adrenal suppression? But if there is, I think it's not of any significance that you really have to consider it for your choice of RSI medication. Does anyone disagree with that?
Brian, what are your thoughts?
No, I agree completely. And I think a lot of the observational work previous to this, including million patient databases, showed increased mortality with etomidate. And it even led some people to call for a strong, either a ban on etomidate or maybe we should just not use etomidate. So when I saw these negative results, including the point estimate favoring etomidate in the sepsis subgroup, I was very reassured that all of those observational studies were probably just findings due to selection bias. Doctors can tell who's more sick and are more likely to use etomidate in those sicker patients. So these randomized trial results ring true to me, and I think it settles the question.
Jonathan, do you feel the same way?
Yeah, I do. I think we're not going to rush out and do a larger trial of this. And I think, to me, the fact that all location mortality being exactly the same, an adjusted difference of 0.0%, and there being no signal of benefit among the highest risk patients, the patients with high Apache scores, patients with sepsis. And we even did the machine learning methods, the individualized treatment effect estimates, and they suggested that there really wasn't any patient you could identify who benefited from either ketamine or etomidate. So I think, to me, this answers the question of mortality, and now it gets into your question. So if there isn't a difference in mortality, then we really care a lot about the procedural outcomes.
Yep, absolutely. So obviously the hemodynamic compromise is a true surprise for me, and I'm curious to hear what you folks make out of it. Now, it was the composite endpoint. There was no increase in cardiac arrest, and there was no signal for that, though we'll talk about VTAC in a sec. We'll put a pin in that. But it really was driven by the need for additional vasopressors or a de novo starting of a vasopressor. Is this coming back with the negative inotropic effects that have always been positive with ketamine? Is it something else? What do you folks make of it?
Well, I'll start by my interpretation of the difference in the cardiovascular outcome. This outcome is the one that we've used in our prior trials, like our fluid bolus trials. It's been used by other researchers in other spaces. And you can't just do hypotension, because if a patient has a cardiac arrest, they may not have a measurable blood pressure. You might give more vasopressors to prevent hypotension. So that's why those three components are there. But the blood pressure cutoff has been kind of arbitrary. We used the one that had been used in prior studies, and no intervention to date has ever prevented hypotension. So no other studies of trials of fluid boluses before intubation, they've always failed. So we don't really know how well this outcome performs. And in this trial, it looked like the difference was driven by vasopressor use. But when you dig into it, that's not really the case. That if you look at different blood pressure thresholds, there's a massive difference in hypotension that is worse in the ketamine group. So there's a difference in the lowest blood pressure as a continuous number. There's a difference in the number of people who experience blood pressures less than 80. And there's a difference in people who had drops in their blood pressure greater than 30 millimeters of mercury. And those, to me, also go in the directions you might expect. So there's heterogeneity in the signal. So the difference in blood pressure is even bigger amongst patients who are really sick, those with high Apache scores, those who are septic, those who are already on vasopressors. So to me, this is a pretty robust picture that there's a big impact on blood pressure, that the difference in vasopressors is not that people are treating people differently in the nature of an unblinded study, but they're responding to differences in blood pressure. And something that's not in the manuscript, but the reviewers asked us to look into, is when people got, what was their blood pressure? Trying to say, were people being treated differently between groups? And the answer is that it was exactly the same. So you were using the same blood pressure threshold in each group to give vasopressors. So I think in the way that we arbitrarily define that secondary outcome, the difference is bigger in the vasopressor administration category, but it's identical difference when you look at other blood pressure thresholds. So I think it is a real difference in blood pressure. But I'll put back to you. So still, is that meaningful to you? So there are people who might question, is blood pressure hypotension during the outcome, even really severe blood hypotension with systolics less than 80, that there's a difference against ketamine in that group, but is that meaningful to you?
I'm going to put a pin in that. That is a question I had on my list, and I definitely want to have us delve into that. I want to explore this area a little bit more. Brian, what do you think is the drive? Because to your point, Jonathan, completely agree. This was not just people deciding to give vasopressors arbitrarily. There was a clear blood pressure signal that they were treating. So, Brian, what do you make of this?
Yeah, people have always talked about this negative inotropy from ketamine and that if you're catecholamine deplete, you can unmask it. And I was always a little skeptical of that, honestly, because we do see ketamine has historically been a pretty hemodynamically neutral drug or sometimes can raise blood pressure and heart rate. So this finding was a big surprise to me as well. But looking at, just as John mentioned, all those great details, I think people were responding to actual real drops in blood pressure and giving vasopressors for a good reason. It didn't always reach that threshold of 65 because the physicians are going to act before there's a crisis and try to keep that blood pressure up. But I think it's a real finding. I think it's an important finding. And I think maybe there is something to that negative inotropy that is only unmasked in the sicker group of patients.
Yeah, I also was skeptical of the negative inotropy effect. And in fact, now I have a manuscript in the works that was actually debasing it based on the extant literature. And now I don't know if I should even publish it, or I'm certainly going to have to alter it quite significantly because I could not find great evidence for it. But this is a signal that suggests something is going on with ketamine that makes it less hemodynamically stable, specifically, or perhaps in a majority of the cases, in septic shock patients. And that was another signal. And the sickest patients, I don't know because we didn't have the data. You guys might. Was the overlap of the highest Apache patients also the patients who had septic?
Yeah, they're overlapping Venn diagrams, but not entirely overlapping. So certainly that's hard to disentangle. And I'll say that it's hard to know mechanism here. We didn't study mechanism. So is it negative inotropy, or is it that ketamine is actually just a more potent vasodilator than we recognized? And all sedatives are vasodilators, but people thought the effects were counteracted by its effects on catecholamines, and maybe it's just a more potent vasodilator. So I'll say that my read of the results doesn't convince me what the underlying mechanism is.
Sure. Yeah.
No, that's very fair. Now, you guys, a little bit into the trial, 500 patients in or so, started seeing a signal of ventricular tachycardia, and then actually started specifically looking for that. What spurred that? What was the signal you guys were responding to?
Yeah, it's interesting, and it's not what you might expect.
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
It's not something we'd observed. It wasn't that clinicians were seeing this and we added it. The truth is that we were planning another study, a study that would be focused on neuromuscular blockade agents. And as part of that, we were just updating our data collection forms and thought, wow, rather than waiting till the study starts, I think we can ask this question in a way that we can embed it in our current data collection forms. And it's always a tension when you're trying to ask, these are clinicians, they're not researchers at the bedside who are collecting these outcomes. And we've tried very hard to limit it to 1 page of outcomes. There are always another dozen things we left off. But this wasn't us responding to events that were being reported and not systematically captured. This was us improving the process mid-trial. And it was around the time that the trial, the funder changed. So the first phase of this trial, the single center feasibility phase, was funded by the NIH. And then we got funding for PCORI to enroll the remaining 1,900 patients. And at that time, we reevaluated all of our processes and said, hey, now that we have funding to do this, as we hope the definitive trial, what are we missing? What can we add? And that's the stage at which we added the questions around arrhythmia.
Gotcha. Now, there was no increase in cardiac arrest rate between the two groups. And yet, so this ventricular tachycardia signal, it's interesting to me. What do you make of this, Brian? Why are these patients?
It's all pure speculation. I really have no good reason why there'd be more VT. Could it just be more hypotension? Could it be the interaction with the sympathomimetic system that ketamine has? I don't know. Honestly, it's pure speculation. I don't have a great rationale for it. I don't know if John has thought more about this.
Jonathan?
Yeah, I think the mechanism of VT we also don't know. Is it negative inotropy or is it a response to hypotension and hypoperfusion? But I think these are small numbers. So I think we should start by saying that this difference is statistically significant, but really small, and it's an exploratory outcome. But it goes in the same direction as all the other cardiovascular outcomes. And I'd say cardiac arrest goes in that direction too. So what we've seen in a lot of our prior trials is that we are powering these for an outcome that we think is important to clinicians because we can't get at the outcomes that we care most about, like cardiac arrest. They're so rare, you'd have to do a trial that's in the tens of thousands of patients that would take decades. So we can't power our trial for cardiac arrest. And then sometimes we're left debating, there's a big difference in this intermediate outcome, but does it matter? And we had that question around hypoxemia a lot. And our colleagues came on your podcast when we did the RSI Trial, and we had the PREVENT trial that showed a difference in hypoxemia, no difference in cardiac arrest, and we were left wondering what that meant. And then we did a trial that was big enough in pre-oxy, and we had the same difference in hypoxemia, and then could prove, because the trial was larger, that there was a difference in cardiac arrest. I think it's the same story here, that there is a signal for more hypotension with ketamine. That signal is real and significant. But I think at this number of patients, we just don't have enough power to detect these rare but important outcomes. And I bet if we had 10 times as many patients, we would see that cardiac arrest and VT are both more common in the ketamine group. But as Brian's saying, that's speculation.
Absolutely. So this might be a subsequent manuscript, and that's why it wasn't there, or you might not have the information, or you might have it just sitting in your front of your minds ready to answer. How many of these ketamine decompensations, and I guess decompensations in both groups, were presaged by clinician awareness of it? By which I mean, some of them, I'm sure, they had a normal blood pressure, they gave the full dose of either of these medications, and then suddenly the patient has this decompensation, versus they were already on vasopressors, they already had hypotension. So that's a very different population in my mind, those two groups. You really don't want the unexpected hypotension. That's a problem. So do we have any idea of the characteristics of these patients who did have the hemodynamic decompensation?
Yeah, it's a great question. We have looked into it in our prior trials and haven't done those analyses here. But certainly you're exactly right historically that there are clearly identifiable risk factors for the people who are going to have these hypotensive events. They sometimes are unexpected, but generally people who are already on vasopressors are the highest risk. People who, despite optimizing them, have lower blood pressures at the time you're pushing drugs are at really high risk. People who have sepsis and high heart rates. A lot of people have looked at shock index. So one thing that we're planning on doing as a follow-up is looking at more granular hemodynamic data in the time before and after. So as mentioned, we're limited in what we can ask clinicians during this emergency procedure, but at least at some sites, we have access to really advanced bioinformatics tools. So we're going to go back and we actually have pulled already, but have not finished analyzing at Vanderbilt, among the pretty significant number of patients enrolled at that center, the minute-by-minute blood pressure, heart rate, respiratory rate, oxygen saturation data. And we're going to dig into those and say, hey, can we use this to identify who's going to experience these outcomes overall, or who has the biggest benefits or harms from ketamine and etomidate? So we're going to dig into that in the coming years. And I'm sure we would appreciate your thoughts on what we should be looking in that space.
I love that. Yeah, that's exactly what I'm talking about. All right, on those same general themes, Brian, you've done previous work on dose reduction and whether it's beneficial, and this is the trial that's really going to answer that question. Do we already have the answer to that, or is that another subsequent manuscript? Should we be doing dose reduction on etomidate? Should we be doing dose reduction on ketamine? Does it decrease the rate of hemodynamic collapse?
So this is a question I'm interested in for sure. I don't know the results of this from RSI. I don't know if John has already done some secret analysis he hasn't told me about. But it's something we definitely are going to look at, because the observational work we did before using a lot of patients from the NEAR database, albeit probably not as sick of a group in NEAR, showed that there was really no association between the dose of etomidate nor the dose of ketamine and subsequent hypotension. That really the hypotension is driven by the underlying patient physiology, not by the dose of the drug. But the RSI trial had over 1,000 patients with sepsis. 20% of them are on vasopressors. It's a really sick group, and I think we really got to dig into that dose response here in this trial. I don't know, John, if you've done a secret analysis yet.
Yeah, our co-investigators have tried to look at this in our prior trials, and it's really hard. What I love about randomized trials is that they're simple to understand on the back end. The dose question is observational, so we really struggle with what to do with dose in this trial. And as you likely saw, we mandated the drug and then allowed clinicians to choose the dose. And we gave them on the randomization sheet the FDA recommended doses and a intermediate dose and a fully reduced dose as provided in the FDA label, and matching what clinicians do in clinical care. but we didn't tell them who to dose reduce or give full doses to. So when you look at people who got lower doses, if you do it just in absolute terms without dose adjustment, it would look like dose reducing hurts people because the sicker people get dose reduced and then they have more events. But that's almost certainly not true. It's probably the opposite. It was helpful to dose reduce, but by how much did it help is a very hard question to answer. So we haven't looked into in this study, and we might, but I don't know if this study will be able to answer that. I think that indication bias can be really hard to overcome, but there are some methods that might help. But I hope Brian eventually does a trial of taking the best medication and comparing doses, and that would be the real way to answer this question.
One of the things that came out of this, a nice little fringe benefit, was demonstration that ketamine doesn't spike the blood pressure. That was often a worry people have that, oh, I can't give it in this patient because it's going to make their BP too high. They're head bleed or something like that, and I don't want to spike their blood pressure. So was that something you guys anticipated, or was that just a nice little bonus we got from the trial?
That was something I thought we were definitely going to see that because you do see it occasionally in clinical practice. And so I thought on average, blood pressure would be increased with ketamine. And it's always a concern for traumatic brain injury and other hypertensive emergencies. And so not finding that I think is helpful. I'm sure it still does raise blood pressure in a few patients out in the world more than etomidate would, but not seeing it in aggregate, I think can reassure us that it's a safe medicine in that respect. Although I think in the sickest of patients, you still obviously worry about the hypotension.
And it's certainly true that we saw people who got hypertensive in this trial. If we said that it never occurs, people would say, I don't believe you. I see it with my own eyes. And it's true that in both groups, there are people who had new hypertension, really significant increases in blood pressure after they got either ketamine or etomidate. But like Brian, I thought even not knowing the other outcomes, we looked at these one at a time in the initial while we were waiting on the statistician. And once we locked the database, I did some of these analyses myself. And even after knowing the mortality signal and knowing the blood pressure signal, and knowing that on average it caused more hypotension, I still thought surely it causes more hypertension in rare cases. And I, like you all, was surprised that it didn't. So I was surprised that on average it caused hypertension in fewer patients than etomidate. And this is really the reason we had excluded trauma patients. So it makes me regret the exclusion of that group of patients from the trial.
Who could know? Now we have the answer to that. So that's in the future will change care for these study protocols. Now, ketamine took longer, and this was statistically significant. Not a time we actually care about that much, but still, I think it speaks to the fact that people are not waiting for their paralytics. Was this something also that you were surprised by to see?
I think you nailed it. Some people might have already asked us why that occurred, and I think your explanation is exactly right. That I think it shows that the paralytics shouldn't be acting differently in these groups. It just suggests that in the etomidate group, people are taking signs of sedation and starting before the patient's fully relaxed. Now, it doesn't seem like there's any harm from that in the short term, at least, although we are also have an ancillary study where we're following up with people about awareness paralysis and PTSD. You could see that going either way. Maybe ketamine's protective against those things in a way that we'll find out. So we'll have a follow-up manuscript on that. But I think you're exactly right that we looked at the duration and broke it down into intervals. So was it longer because they waited longer to start laryngoscopy, or was it longer because it was harder to do laryngoscopy? Did it somehow affect the difficulty intubation? And the laryngoscopy and breathing tube placement period was exactly the same. So it's all driven by when clinicians started. And I think you're exactly right that people in the etomidate group, they're sedated and they stop moving, and people start. And in the ketamine group, they're dissociated, but they don't stop moving until paralytic takes effect, and it just takes longer.
There you go. Okay, that's fantastic that you have that granular explanation. Brian, anything you want to add to that?
No, just that rushing laryngoscopy is something that people will do from now to the end of time. I can't stop my residents from doing it. It's impossible. I almost want to give up, but so I think when someone looks asleep, people will proceed with laryngoscopy. It's just a truism in medicine.
There you go. All right. So now as we're coming towards the conclusion, we could see it in sight. We'll get to Jonathan's question he had asked earlier, which is what we should do now. And do you guys want to go first and then I will give mine, or do you want me to tell you where I stand?
I want to hear Brian's. I don't know it yet.
All right. Then let's start with Brian and we'll do Jonathan and then I'll tell you mine. What you're going to do now post RSI in terms of
what drug are you going to give to your next patient?
You could go as detailed as you want for how you're going to manage clinically. And then maybe after that, we'll talk about where you guys are going next on research. But let's talk first on your clinical practice, Brian. With the results of this trial now in front of you, what are you doing?
We used a lot of etomidate before the trial, some ketamine, but I think I'm going to transition to using mostly etomidate. But knowing that has less chance of hemodynamic collapse is important to me. Although there are some cases where I still might use ketamine. If I think timely post-intubation sedation is going to be difficult, ketamine has an advantage there. And someone who I really don't think has any risk of shock and the resident wants to use ketamine, I probably won't stop them, although I don't think I would necessarily choose it myself. But I think the higher risk of hemodynamic collapse with ketamine is important enough that there's not too many good reasons to use it, but I think you can think of a few.
Jonathan.
Yeah, so I always joke that when you do comparative effectiveness trials comparing two strategies, the only response you ever get is, I already knew that, or I don't believe that. So I'll be interested to hear what we hear from your audience. But this is a case in which I was using etomidate before the trial, and this certainly didn't change my practice to start using ketamine. And I would say that many of our prior trials have gone in directions I didn't expect. So I wasn't providing positive pressure ventilation before prevent and preoxy. I didn't know which way device would turn. So many of our prior trials have changed my practice. And I still am interested in hearing whether this is practice changing for people who are ketamine only intubators. But for me, as someone who used etomidate, certainly it's not going to push me in the other direction. All right. What about you, Scott?
I was a almost all ketamine provider. So I will say for RSI, I'm probably going to switch to etomidate for many of my patients. Now, when will I continue using ketamine? When I'm performing delayed sequence intubation. Now, obviously, I have a bias towards enjoying that technique, but it allows me to, first of all, give a very low amount of ketamine and then see the hemodynamic results of just the ketamine prior to transitioning that patient to positive pressure ventilation. So I really feel if there is an unanticipated hemodynamic compromise, it's going to be small and allow me to mitigate prior to the administration of paralytics and the change of the patient's entire physiology. And DSI, we were doing pretty routinely. In fact, we had transitioned most of the people when I work with them to not RSIing and DSIing. I'm probably going to decrease the number of those. I'm probably now going to DSI specifically for a patient group where it's necessary, and then RSI with etomidate for most of my patients until more data emerges. So I'd love to hear your reflections on that. And I know you have used DSI, Brian. Will you continue using it? And will this lead to decreasing the number of patients you DSI?
Before Brian goes, I just want to say to your audience, you heard it here, folks, that Scott said that he neither knew this before nor didn't believe it, and we're going to change his practice. So I've met my life goals.
I think anyone who doesn't change their practice based on new evidence shouldn't really consider themselves a adept clinician.
Yeah, no, I think there's definitely still a role for delayed sequence intubation, and ketamine is going to be the drug of choice given its duration and rapidity of action there. Whether you would do that in someone who's shocked, you probably do that much less often. But yeah, for sure. I think if you need to perform some key procedures before you give the paralytic, ketamine is still a super valuable drug for those patients.
I'll just say I agree that there still may be a very logical patient population for whom you choose the medication, particularly if they're people like you say, who might be high risk for hypoxemia or impossible to pre-oxygenate otherwise, particularly if they're low risk for hypotension. And you mentioned before that we might talk about future research, and this is, if it's okay, a natural bridge to
absolutely.
one of our upcoming studies. Our mentee, Stephanie DeMasi, just got her Career Development Award to do a single center pilot trial of intubation with sedation alone versus sedation with neuromuscular blockade. And I think in the era of video laryngoscopy, where the tools have gotten so much better and our success rates are so much better, that question needs to be reevaluated. And you can imagine that if the sedation-only group is safe and not worse with regard to success of intubation in the first attempt, that ketamine might be an appealing drug for a lot of patients to allow them to continue to breathe while you're doing laryngoscopy and placing the breathing tube. So we'll see. I think that for me, this has certainly answered the question when I do RSI, but I agree with you. There may be certain patient populations for whom a delayed sequence approach works, and things might change if we reevaluate the entire RSI paradigm.
All right. Brian, where are you going with this post-RSI?
Yeah, I'm really excited to see the results of this pilot trial at Vanderbilt. And I know, Scott, you are too. It's been a love of yours, the sedation-only, ketamine-only intubation. Super excited for that. In terms of future trials, right now we're leading a trial at a Hennepin that's trying to establish any difference in performance of colorimetric CO2 detection versus waveform capnography to confirm tube placement. Just because there's some really strong guidelines advocating and saying waveform is the only way, and that's what we use at Hennepin. But tons of major medical centers in the United States and across the world still use color. And so there's a disconnect between the guidelines and real practice, and I think it's because there's not enough current evidence to really push people one way or the other. I know waveform obviously gives more information, but we'll be excited to share those results when we get them, probably end of next year.
All right.
We have two other airway trials, if it's okay for us
to
mention them. We are currently enrolling in the BREATHE trial, which randomizes patients to smaller or larger breathing tubes. and looks at the impact of breathing tube size on long-term breathing, speaking, and swallowing, really exploring some signals that people have shown in observational data that the tube sizes we're placing are causing injury to the larynx and long-term functional disability. And the safety outcomes in that trial are around, are we still able to perform bronchoscopy? Can we still get people off the ventilator as quickly? Is there any impact on mortality? So that's a 3,160 patient trial that was funded by PCORI, and we're about 600 patients in. And the other trial that we're getting ready to start is led by Stacy Trent at Denver Health and Stephanie DeMasi here, and it's the ANGLE trial. And that is a follow-up to the device trial comparing hyperangulated blades versus standard geometry blades during videolaryngoscopy. So we're excited to be doing a lot of cool work, and hopefully we'll be back here talking to you in the next few years.
The Pragmatic Trials group is doing amazing shit. I am just continuously impressed. It's such good stuff. So what did Ed and Todd ask that I should have asked?
They asked a lot of junk questions. Tell those guys they're close friends. Tell them they're total garbage. They don't know anything about trials. No, they ask the same questions as you. So I think they work in the same unit I do. So they have always been accommodate guys. So I was not surprised to hear that their practice wouldn't be changed by these results. So you're the first person we've talked to outside the network who is a ketamine person, and we're really grateful to have a chance to hear your thoughts on it.
That's fantastic. All right, what should we have said that we did not? This is your last chance to speak to the listeners before we sign off.
I'll just say that this work has been inspiring, and this trial is funded, but a lot of our prior work has been on volunteer effort. And this is an important space where when we started doing this work 10 years ago, there were millions of people being intubated every year. The rates of complications were super high for this brief 2-minute common procedure. And it's been really gratifying to see people across the country, Brian, all of our colleagues in the Pragmatic Critical Care Research volunteer their time and effort. We've had patient investigators join our group and really help us make sure that we're telling patients the right thing and informing the community in the right way, informing patients who were intubated in our trials in the right way. So it's been gratifying to see a network, and we include you in this, that's really rallied around this important clinical area and helped us improve outcomes. And I think we're making progress. So it's an exciting time.
Fantastic. Brian?
Yeah, I would echo that. The PCCRG does great work because of all the great people we work with. And enrolling this really sick cohort of patients as part of routine clinical care is just astounding. To get patients, over 1,000 patients with sepsis, and really definitively answer this question is wonderful. And I look forward to trying to answer more questions.
All right. Lovely to talk to both of you. This is fantastic work, and I'm so happy to have you on. Thank you again.
Thanks, Scott.
Thanks, Scott.